Patients with autoimmune diseases will often have multiple autoimmune diseases at the same time, and one of the very classic pairings in patients with rheumatoid arthritis is Sjogren's syndrome. How will a patient with Sjogren's syndrome present? Classically, there's a triad of 3 symptoms that are seen. Xerophthalmia, which refers to dry eyes, but may present with patients saying they have the sensation of sand in their eyes, namely because they're not producing very many tears. Xerostomia, which means they have the sensation of a dry mouth, which can also cause dysphagia, because chewed food is just not being lubricated enough to make it easy to swallow. And the third thing is arthritis. So what's the underlying mechanism of pathology here? The exocrine glands are being destroyed, especially the lacrimal and salivary glands that give rise to 2 major symptoms. Patients with Sjogren's may also present with parotid enlargement, which occurs because it is only the submandibular and the submaxillary salivary glands that stop producing saliva, while the parotids have to make up the difference, and they compensate by enlarging. What else might you see associated with the disease? B-cell lymphomas, which are more likely in patients with autoimmune diseases as a result of chronic inflammation, which predisposes to dysplastic changes. Dental caries are also more likely because saliva has a number of chemicals that will aid in dental health, but without these enzymes, the teeth are more likely to have bacteria and significant plaque buildup. The antibodies to know for Sjogren's disease are anti-RNP, anti-SSA, or Rho, or anti-SSB, or anti-LA, with Rho and LA being the more important ones to remember. SS in the name stands for Sjogren's syndrome, so that will make it easy to remember. So how will this patient present? It's likely going to be a 40 to 60-year-old woman with a history of rheumatoid arthritis. Let's have a flash quiz. What disease process is most likely to cause a patient to complain of sand in my eyes? The answer is Sjogren's syndrome. Look for dry mouth too. If you hear about xerostomia and xerophthalmia, think Sjogren's. The next disease we'll discuss is gout, a relatively common disease that's important to know very well. You will see it on step 1 and also on the wards. You need to differentiate this joint pain from osteoarthritis, rheumatoid arthritis, or other joint pathology. Biochemically, this disease is characterized by precipitation of monosodium urate crystals into the joints due to high serum uric acid levels. What's the gout catchphrase? Negatively birefringent crystals, or yellow crystals in parallel light. You can use the double L mnemonic highlighted here to help you remember the chronic treatment too, allopurinol. There are a lot of causes of gout, theoretically due to 2 major problems. Uric acid can either be overproduced or underexcreted, which can cause high serum levels, thereby leading to higher likelihood of crystal deposition. Of the 2, underexcretion represents 90% of cases. Commonly, your patient will have just started on a diuretic, such as furosemide, so look out for the CHF patient on diuretics with acute knee pain and a question stem. Do you recall from biochemistry how Lesch-Nyhan syndrome works? HGPRT deficiency causes a buildup of uric acid. Patients get that uric acid frost, and, you guessed it, horrible gout. PRPP excess also occurs in patients who have mutant PRPP synthetase, causing it to be insensitive to feedback inhibition. So what builds up? Purine nucleotides and uric acid. What about von Gerke disease? Here, you have glucose 6-phosphatase deficiency. How does it result in hyperuricemia? Well, increased levels of G6P is metabolized by the pentose phosphate pathway to generate uric acid. What other metabolite is overproduced in von Gerke? Lactic acid, which competes in the renal tubules with uric acid for excretion. Thus, for these inborn errors of metabolism, patients have both increased production and decreased excretion of uric acid. Certain medications and increased cell turnover can also result in hyperuricemia and gout. The case vignettes are always rather similar, usually with some external insult leading to a gouty flare, likely in a single joint, and most commonly in the MTP of the great toe. A classic example is a patient who is treated with chemotherapeutic drugs for leukemia, who turns over cells very quickly due to rapid cell death from the chemotherapy, leading to a huge overproduction of uric acid. This precipitates a gouty attack, thereby causing a man being treated with a standard therapy for his cancer presenting to your clinic with intense, extreme joint pain. How do oncologists anticipate this problem? By pre-medicating all patients with large tumor burdens with allopurinol, a blocker of uric acid production, to prevent it from being created and allowing serum levels to stay low. We'll go over the mechanism of allopurinol later in the pharmacology section. So how does gout present commonly? The symptoms of gout classically consist of an asymmetric joint distribution, and often a red, swollen, painful joint, most commonly the MTP of the big toe, as pictured here as well. With long-standing gout, the crystals can precipitate into deposits called tophi, or tophaceous gout. These tophi can be anywhere, but classically appear on the external ear, olecranon bursa, or the Achilles tendon. Why do the crystals form here? It's basic chemistry. These areas are just a few degrees cooler, and so crystals more readily precipitate. The tophi themselves don't really cause that many problems. It's actually the acute attacks that are very, very painful, and they don't occur at the sites of the tophi necessarily. So what will precipitate an attack? Things like large meals or by drinking alcohol, both of which allow for uric acid levels to increase. With alcoholism, as with HIV and other important chronic diseases, it's important to build a list of common complications and diseases that often present with them so that you can use it as a shortcut when you see them in a clinical vignette. This is a great one to add to the alcoholism folder in your brain, along with thiamine, B12 folate deficiency, and DTs, which you'll remember from the biochem chapter. Why does a long night of drinking result in a gouty attack? Alcohol metabolites compete with uric acid in the kidney for excretion. The treatments for this disease are varied, and usually determined by the clinical presentation. What can we do for patients acutely? The goal here is not to try to acutely drop their serum uric acid level. The goal is to control their pain and inflammation. What drugs work great for this? Think about NSAIDs and steroids and sometimes colchicine. Once the acute flare has resolved, the next goal is to try to reduce serum uric acid levels and keep them low so that patients are less predisposed to acute attacks. This is mainly accomplished by allopurinol, which inhibits the formation of uric acid, and less commonly probenecid, which causes the kidney to excrete more uric acid. Let's have a flash quiz. What drug can you give to prevent a gouty attack due to tumor lysis syndrome? Allopurinol. Here's a pro tip. Should you start allopurinol out of the blue on a patient with sky-high uric acid and gout history? No, you'll absolutely precipitate a flare. Start colchicine instead, so long as the patient doesn't have CKD. Pseudogout is just like gout, but a different type of crystal. We aren't dealing with uric acid anymore, but calcium pyrophosphate crystals. How can you distinguish gout from pseudogout? One thing that might raise your suspicion is gouty symptoms in a large joint, like in the knee. Pseudogout is usually in the larger joints. The definitive distinction is in the crystals. Pseudogout crystals are weakly positively birefringent, which means they are blue when parallel to the light. Additionally, because they have calcium in them, these crystals are visible in the joint space on X-ray. Just remember that P is for both pseudogout and for pyrophosphate. Patients are usually older and can be male or female. You should look for patients with this kind of history: hemochromatosis, hyperparathyroidism, or osteoarthritis. You can treat an acute attack with NSAIDs or glucocorticoids. Patients also benefit from colchicine for prophylaxis. What shape are pseudogout crystals? The answer is rhomboid. Infectious arthritis is quite often an orthopedic emergency. Why? Because it's a raging infection that is restricted to a very small space in a joint. Usually, it presents in a single joint that may then move to another joint and often moves asymmetrically. There are some classic organisms that cause septic arthritis. Most importantly, Staph aureus and Streptococcus, and Neisseria gonorrhea. The boards love gonorrhea arthritis. The patient is a teenager with migrating arthritis and a red, hot, raging joint, often the knee. Think of gonorrhea. How do you treat gonorrhea? Ceftriaxone. What else should you be suspicious of? Chlamydia and any other STDs. When you see the teenager and joint pain in a question, your brain should automatically go to this. Let's have a flash quiz. Teenager plus sex plus joint pain equals gonorrhea and probably a septic joint. Seronegative spondyloarthropathies. It's a long term for a somewhat straightforward set of diseases. Basically, these are a group of 4 inflammatory arthritides that affect the spine and are seronegative. That is, they have negative serologies for rheumatoid factor. More commonly, these diseases affect males. What do you need to know about the seronegative spondyloarthropathies? HLA-B27, a gene that helps to encode for MHC1 molecules, is strongly associated. Again, there are 4 types of seronegative spondyloarthropathies, including psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. A list you can remember with the memory aid PAIR, P-A-I-R. Psoriatic arthritis is psoriasis and joint pain and stiffness. Clues on radiography are often giveaways. For example, a pencil-in cup deformity, as well as dactylitis or sausage digits. These are some of the buzzword phrases that should immediately take your brain to psoriatic arthritis. Ankylosing spondylitis is probably the most classic of all of the seronegative spondyloarthropathies. What does this X-ray of the spine look like? Like bamboo, because of exophytic bone formation, causing the vertebrae to square up and stack up. It's a disease characterized primarily by chronic inflammation in the spine, classically in the sacroiliac joints, and then ascending up through the spine. As it ascends, it causes fusion of the spine, eventually leading to a complete loss of mobility. Additional symptoms include uveitis and aortic regurgitation, 2 important symptoms to know as they can be common and should not confuse you on the step. The next arthritis discussed here is the one associated with IBD. There's no single differentiating symptom that you need to be aware of here, but expect that sacroiliitis that occurs in patients with pre-existing IBD is because of this seronegative spondyloarthropathy. Do you remember the 2 types of IBD from the GI chapter? That's right, Crohn's disease and ulcerative colitis. The final type of arthritis here is reactive arthritis, which used to be called Reiter's syndrome. It's known for a classic triad of conjunctivitis, urethritis, and arthritis, but can be remembered with the memory aid can't see, can't pee, and can't climb a tree. This is a great way to remember all these fully testable concepts. What will alert you to Reiter's? A recent history of a GI or chlamydial infection, because these infections are what precipitate eventual reactive arthritis. Alright, let's have a flash quiz. What MHC molecule is strongly associated with the seronegative spondyloarthropathies? HLA-B27. And now we're on to lupus, the great imitator. There are a phenomenal number of ways that lupus presents, and it has a capacity to be a very different disease for many different types of people. But don't worry, there are some consistencies, and this is what you'll be expected to keep in mind. First off, let's do some epidemiology, which is often very important for this disease. 90% of patients are female and between the ages of 14 and 45. Most of these women are Black, a population that also tends to have more severe cases. Though I won't say it's impossible, with a gender skew like this, I'll say that it's very, very, very unlikely that you'll see a male with this disease on step 1. So have it in your mind whenever you see a young woman with something that seems autoimmune in nature. Like I said, the symptoms are extremely varied. And unfortunately, there are a lot of non-specific symptoms. The non-specific ones include fever, fatigue, and weight loss. Lupus can affect literally every organ of the body, but you'll need to know about specific problems in the heart and the kidney. So what happens in the heart? Liebman-Sachs endocarditis, which you may recall from the cardio section. Here we see warty small growths, likely on the mitral valve. Do they cause dysfunction? Not really. Do they embolize? No, not really. Is anything growing there? Not really. They're mostly fibrin and neutrophils. Okay, what else can happen to the heart in lupus? Pericarditis, and it's the most common cardiac manifestation. Do you remember the symptoms of pericarditis? Chest pain that's relieved by tripoding and exacerbated by lying down or taking deep breaths. Lupus nephritis comes in at least 2 ways. The first is nephritic, which is diffuse proliferative glomerulonephritis. Nephrotic, on the other hand, is a membranous glomerulonephritis. Why did the kidneys take a hit? Immune complex deposition. What type of hypersensitivity reaction would that be? 1, 2, 3, or 4? It would be type 3. In fact, the symptoms that you really need to know about are captured in the mnemonic rash or pain. This includes immunoglobulins, which we'll discuss in some detail in a moment, as well as a wide variety of symptoms, including the classic rash, which is a malar pattern distribution, arthritis, soft tissues, hematological problems, oral and nasopharyngeal ulcers, renal disease and Raynaud's phenomenon, photosensitivity, antinuclear antibodies, immunosuppressants, and neurological disorders. What kills patients with lupus? Cardiac disease is particularly deadly in these patients, and you'll regularly get EKGs on patients. If you become a rheumatologist, sometimes these patients suddenly die, and you presume it was cardiac in nature. Since these patients are immunosuppressed, they're prone to infections that can be fatal. What else can immune dysregulation lead to? Malignancy. And finally, these patients can succumb to renal disease. In making the diagnosis of lupus, there are a number of serologies that are classically ordered to help confirm the diagnosis. The 4 that we'll discuss here are ANA, anti-double-stranded DNA, anti-Smith, antihistone, and anticardiolipin antibodies. ANA is probably the best known of these, and while it has good sensitivity to help ensure all the cases are picked up in screening, it's not very specific for lupus, and further testing and clinical evidence is often needed. The second antibody, anti-double-stranded DNA, is a much more specific indicator, and usually indicates severe disease. Do you recall from biostats the order in which you'd want to get these 2 tests? Good. The sensitive one first, followed by the specific one, so ANA followed by double-stranded DNA. Similarly, the anti-Smith antibodies are very specific for the disease. If you're questioning if a patient has lupus and don't think you can go off clinical evidence alone, ANA positivity usually is good to help guide your diagnosis. but double-stranded DNA and Smith antibodies really confirm your suspicion. And what about antihistone antibodies? These antibodies are actually not related to lupus. They are related to a disease known as drug-induced lupus. It may have similar clinical features, but drug exposure is a crucial piece of confirmatory evidence. Which three drugs classically cause drug-induced lupus? Hydralazine, used for severe hypertension, procainamide, an antiarrhythmic, and isoniazid, an anti-TB drug. These can be remembered with the acronym HIP, as in, it's really not hip to have lupus. Anticardiolipin antibodies, while associated with lupus, have another important clinical pearl. These antibodies can cause a false positive on RPR and VDRL titers. Why? RPR and VDRL have cross-reactivity with anticardiolipin antibodies. And so what might you misdiagnose your lupus patient with? Syphilis. These antibodies also prolong PTT. Although labs will show prolonged PTT, patients with these antibodies actually have an increased risk of arteriovenous thromboembolism. What effect on the complement system might you expect in a patient with lupus? C3, C4, and CH50 are all low because of immune complex formation and deposition. Where might you biopsy to see this immune complex deposition? The kidneys, and even in the skin. The treatment of lupus is very complicated. What you need to know is treat with NSAIDs, steroids, immunosuppressants, or hydroxychloroquine. Do you recall what else hydroxychloroquine is used for? Malaria. What tumor is described as onion skin appearance in the bone? Ewing sarcoma.